Start recording.
Start பண்ணிடலாமா? No. Start.
Start up. A very good evening to one and all present here who have joined us for today's session. On account of World Thalassemia Day, we have a special integrated lecture from our most respected Professor Dr. Jamuna Rani ma'am, Professor and HOD of Department of Pathology, Bhaarath Medical College. She is also the faculty advisor for medicine. I welcome you, ma'am, for joining us today for this session.
Good evening, Parthiban.
So without any further ado, we can start the session.
Okay. So is the screen visible?
Yes, ma'am.
Okay. So very good evening, one and all. So on account of the World Thalassemia Day, so it gives me immense pleasure to deliver this thalassemia talk. And from the UG point of view, from the NEET examination point of view, thalassemia topic is really very, very important. So we'll just brush up the pathogenesis and to a certain extent on the management of thalassemia. So as all of us are aware, so hemoglobin in an adult, so normally we have hemoglobin A, which constitutes 97%, hemoglobin A2, which is 2.5%, and we have the fetal hemoglobin, which is just 0.5%. So why we should be knowing these values? Because when we interpret hemoglobin electrophoresis, so these values will be significant. So if there is elevation of hemoglobin A2 more than 2.5% or fetal hemoglobin more than 0.5, it is really significant. So to brush up the basics, as we are already aware, so this is the adult hemoglobin molecule that is which has alpha 2, beta 2, isn't it? So this is a hemoglobin A, that is the adult hemoglobin. And as you can see here, the 2 alpha and 2 beta, and there are 4 iron molecules in that which will bind with oxygen. So always remember the active form of iron is Fe2+. That is the ferrous form. Okay. And ferric form will be used for storage, whereas the ferrous form is the most active form. So how do we classify hemolytic anemias? So generally, how do we classify anemia? So anemia can be because of nutritional deficiencies, increased destruction of RBCs, that's what we call as hemolytic anemias, or decreased synthesis in aplastic anemias, in nutritional anemias, etc. And finally, anemia because of blood loss. So this is how we classify anemia. So what are the causes of increased destruction of the RBCs? So the first and foremost would be inherited genetic defects. So in inherited genetic defects, so the problem can be either in the RBC membrane or it can be in the enzymes. So the problem with the RBC membrane, one is hereditary spherocytosis, hereditary elliptocytosis. So all these diseases involve problem with the RBC membrane. So the problem with the enzyme, as you are aware, G6PD deficiency and pyruvate kinase deficiency. So these are the problems with the enzyme. Then we have the hemoglobin abnormalities where, so hemoglobin abnormalities can be because of decreased synthesis of the globin chains. So that's what we are talking today, that is thalassemia. Or it can be because of abnormal hemoglobin. That is, for example, sickle cell anemias. So they are because of abnormal hemoglobin synthesis. Okay, so that is hemoglobin abnormalities. Then acquired genetic defect. So please remember the one and only cause of acquired genetic defect. Okay, so what is that acquired genetic defect? So it is PNH, peroxisomal nocturnal hemoglobinuria. So the only acquired genetic defect is PNH, followed by antibody-mediated destruction. So antibody-mediated destruction can be because of RH diseases, hemolytic disease of newborn, or any autoimmune disorders. Then we have mechanical trauma. So in mechanical trauma again, so please remember this MAHA, microangiopathic hemolytic anemias, where we have HUS, hemolytic uremic syndrome, and TTP, thrombotic, thrombocytopenic, purpura. So mechanical trauma, and other causes of mechanical trauma can be because of abnormal cardiac valves, repetitive physical trauma in cases of unaccustomed runners who are doing marathons, new military recruits. So all those things are causes of mechanical trauma. So coming to the membrane lipid abnormalities, of course, they are very rare causes, but remember again, A beta lipoproteinemia. So that is a cause of membrane lipid abnormality. Then we have sequestration, splenic sequestration. Whenever there is a splenomegaly, so spleen will engulf all the RBCs. So sequestration by the spleen. And finally, remember infections and toxins, which are the most common causes of hemolytic anemia in adults. So infections, all the infections, malaria and toxins, poisons, clostridial sepsis, snake venom, lead poisoning. So all this constitute the infection and toxins. So this is how we classify hemolytic anemia. And today's topic is focusing on hemoglobin abnormalities. Specifically, we are going to discuss on thalassemia. So what is thalassemia? A genetically heterogeneous disorder. It is because of germline mutation. So remember, sickle cell anemia, hereditary spherocytosis. Hereditary spherocytosis is autosomal dominant. Sickle cell anemia, point mutation. Thalassemia, multiple etiologies. So, but all these things are inherited. So the mutation is in utero. So they are all germline mutations. And remember, alpha globin gene on chromosome 16. See, as you can see here, it is identical pair. So it means if you have a chromosome, so the alpha globin, I'm sorry. Yeah. So the alpha globin chain is like this. Okay, so identical pair on chromosome number 16. Whereas the chromosome 11, the beta globin gene, it is in a single focus. So here it is. So this is chromosome 11. Okay, so this is alpha, this is beta globin gene. Okay, and coming to the pathogenesis, remember the pathogenesis in thalassemia is because of two things. One is a deficient globin chains. If it is beta thalassemia, it is a beta globin genes which is deficient. So beta globin synthesis is not there. Alpha, it is alpha synthesis is not there. But the problem is not only because of the deficiency, but also because of the increased destruction. So that is hemolysis. So the problem is because of deficiency of the chain and increased destruction, hemolysis. So why there is a hemolysis? See, when there is a deficiency of beta, what happened? The adult hemoglobin is alpha 2, beta 2. So you need exactly equal number, 2 alpha and 2 beta. So what happens when beta is reduced? So this alpha in excess. So this excess will accumulate on the surface of the RBC, causing damage to the RBC membrane. So remember, in thalassemia, pathogenesis is because of deficiency and destruction. Yes. So this is the most important point, malaria endemic zones. So what happens? Going with the Darwinian hypothesis of survival of the fittest, what happened? Areas which had so much of malaria, the malarial parasite is basically proliferating inside the RBCs. So what happens? The lifespan of RBC is 120 days. So in that time, what happened? The malarial parasite can complete its entire life cycle and spread on to the other RBCs as well. So in all these disorders like thalassemia, sickle cell anemia, even in hereditary spherocytosis, in all those diseases, what happened? There is an early destruction of the RBCs. So the malarial parasite will not be able to complete its life cycle. So in those areas, what happens? These genetic abnormalities were very high in malaria endemic zones because the death fatality due to malaria, especially falciparum malaria, was very high. So by theory of natural selection, these thalassemia mutations were circulating among the families. So malaria endemic zones, the prevalence of thalassemia, sickle cell anemia, all those abnormalities in the RBC membrane and hemoglobin were very much predominant. So the topic, beta thalassemia. So remember, germline mutation in beta thalassemia can be because of splicing mutation, promoter region mutation, finally chain termination mutation. The most important MCQs here, splicing mutation. So splicing where? So splicing in the RNA. Okay. So this mutation can either, if there is a mutation in the normal splicing areas, what will happen? Beta globin genes, the chains will not be produced. Okay, so beta globin is not synthesized, so the person can have a, I'm just sorry. the person can have a beta 0 thalassemia if there is a splicing in the normal splicing site. If there is a splicing in the abnormal site, what will happen? Normal splicing site is normal. There is abnormal splicing site which is also created. So normal beta globin chain synthesis will be there, but in reduced amount. So you can also have beta 0 or beta plus thalassemia when there is a splicing mutation. But remember, most common cause of beta plus, that is thalassemia intermedia and thalassemia trait, is splicing mutation. Mutation in the promoter region, it is beta plus thalassemia, because mutation in promoter region will again have normal beta chains as well as abnormal beta. So it is beta plus thalassemia. See, at this point, it is chain termination mutation. For whatsoever reason, the chain is terminated because there was a stop codon that was produced there and the chain is terminated. So whenever there is a chain termination mutation, definitely normal beta globin will not be produced at all. So most common cause of beta 0 thalassemia is chain termination. The chain is terminated, so beta globin synthesis will be fully stopped. So beta 0 thalassemia is chain termination mutation. Most common cause of beta plus thalassemia is splicing mutation. Promoter region would cause beta plus, but the most common reason for beta plus is splicing. Beta 0 is chain termination. Very important MCQs. So coming to the classification, we classify beta into 3 categories: beta thalassemia major, intermediate, and minor. So whenever we have major, it should be beta 0, or both beta plus, but the synthesis is maximum reduced, or one is beta 0, other is beta plus, but with a very, very reduced globin synthesis. So the other clinical term for beta thalassemia major is transfusion dependent thalassemia. Beta thalassemia intermedia, they are non-transfusion dependent thalassemia, whereas beta thalassemia minor, they are asymptomatic, will present in the adulthood. Here, the take-home message for beta thalassemia minor is, so this is the most common DD for iron deficiency anemia. Okay. So the significance is we need to differentiate iron deficiency anemia. See, they will be presenting like iron deficiency anemia. The hemoglobin will be around 10 or 9, like that only. For beta thalassemia minor, the most important significance, why should we be diagnosing beta thalassemia minor, is because it is very important for, because it is a germline mutation, chances of the next line family member might be affected, the next generation might be affected. So genetic counseling is mandatory for there is a defect in the globin chain. So if there is a defect in alpha globin chain, it is alpha thalassemia. If the defect is in the beta globin chain, it is beta thalassemia. So here we are looking into the pathogenesis of beta thalassemia. So what happened, as I already said, the mutation can be because of RNA splicing, problem in the promoter region, or the problem in the chain termination region. Again, to insist, chain termination, it is the most common reason for beta 0 thalassemia, and RNA splicing is the most common reason for beta plus thalassemia. So because of the defect in the globin chain, what happens? So there is a reduced beta chains and excess alpha chains. So what will happen? Because of this, normal hemoglobin synthesis will not be there. So reduced hemoglobin will be there. So because the amount of hemoglobin within RBC is very less, what will happen? The RBCs will also shrink. So how the RBCs will look? They will be microcytic, hypochromic RBCs will be there. There is not only reduced beta chains, but also excess alpha chain. So what will happen? These excess alpha chains will be insoluble and they will be depositing in the RBC membrane, causing RBC membrane damage. So whenever the RBC membrane is damaged, what the body does, the bone marrow will initiate apoptosis of the erythroid precursors. Even before they come into the peripheral blood smear, all these abnormal RBCs with the insoluble alpha chain precipitates will be destroyed within the bone marrow itself. So there is a apoptosis. Apoptosis is programmed cell death, which happens inside the marrow. Okay, so don't confuse this with the hemolysis. Hemolysis is happening when the RBCs come into the peripheral blood. So here there is an apoptosis and ineffective erythropoiesis. So what do I mean by ineffective erythropoiesis? So when we say it is effective, suppose a patient is having anemia, hemoglobin of 8, And what the body does, the peripheral blood senses it. The oxygen carrying capacity is very low. So what happens? It sends a signal to secrete erythropoietin in the kidney. So that erythropoietin goes and tells the marrow that, see, the hemoglobin is low. The person needs at least 3 grams of hemoglobin excess. For example, if the hemoglobin is 8, at least 11 grams is needed for the physical activity. So you start producing more of RBCs. So there will be erythroid hyperplasia and more amount of erythroid precursors will be released into the peripheral blood. So how do we measure the erythropoiesis in the peripheral blood? What is the most important test we do? That is reticulocytes, isn't it? Reticulocyte count. So when I do a reticulocyte count, for example, a person with iron deficiency, and we are giving iron injection or iron tablet, how do I monitor the progress? How do I know that iron has been taken up in the marrow and there is a erythropoiesis? I do a reticulocyte count. So when the reticulocyte count is higher, I understand that, okay, so the message has reached the marrow and marrow has started producing the RBCs. Okay, so in thalassemia, what happens? Same thing is happening. The hemoglobin of the poor person is 3 gram or 4 gram. There is more of erythropoietin is produced from the kidney and it is going running and telling the marrow that, see, you have to work very hard. Yes, marrow understands, it works day and night. There is a massive erythroid hyperplasia. Unfortunately, what happened? The problem is with the insoluble alpha chains. All the erythroid precursors will have the insoluble alpha chains, and all these alpha chains will be causing membrane damage, which will stimulate apoptosis, leading on to premature destruction of the erythroid precursors within the marrow. So whatever is the net output, what are the RBCs that comes out of the marrow? Again, it is an ineffective erythropoiesis. So what was expected is not happening. So in thalassemia, what happened? Reticulocyte count will be elevated, but not to the degree of anemia. See, for example, if the hemoglobin is 4 gram, when you give supplements, iron supplements, and you wait, definitely the reticulocyte count will drastically improve. When I do a reticulocyte count, it will be around 4%, 5% like that. Whereas in thalassemia, because of ineffective erythropoiesis, reticulocyte count will be hardly 2.53 like that. So there won't be effective increment. That's what is called as ineffective erythropoiesis. Okay, so again, reduce beta chains and excess alpha chains. These excess alpha chains will be accumulating in the RBCs. So whenever we see the peripheral smear, there will be microcytic hypochromic RBCs. Along with that, you see these target cells. So these are the target cells. Okay, so what is this target cell has? It is the excess alpha chains which will be accumulated as target cells. So again, reduced hemoglobin since birth. So the baby will have anemia since birth. So it means all the entire organs of the child will have tissue hypoxia. So because of tissue hypoxia, what will happen? The organs will not develop. So the child will have developmental delay. And because of anemia since birth, what will happen? There is a massive erythroid hyperplasia. So where is the erythroid precursors being produced? In the marrow. And there would be some amount of extramedullary hematopoiesis as well. So what happens? All the marrow will get widened. And so what happens? You get the classic X-ray picture of the skull that is called as a crooked appearance or hair-on-in appearance. So why this appearance happens? Because why it is very much visible in the skull? Because in the child, the fontanelles are not yet closed. So there is more space for expansion. So it is very dramatic in the skull. So you get the haircut or hair-on-in or crooked appearance in the skull. Then let's again come back at this place. So we have target cells. And because of these target cells, what happens? Whenever these target cells enter into the spleen, there is an extravascular hemolysis because the spleen thinks, I have to clean these RBCs. That is a normal work of the spleen, isn't it? Culling and pitching of the RBCs. So it is trying to clean all the RBCs. So what happens? There is restriction of the RBCs leading on to extravascular hemolysis. So who is doing this extravascular hemolysis? It is the spleen. So the patient will have splenomegaly. Okay, so the spleen will be enlarged. Also, because of ineffective erythropoiesis inside the bone marrow, what will happen? It needs more of nutrients because there is a massive erythroid hyperplasia. Despite I'm doing a good work, I'm not seeing the results. So I'm increasing the workload 20, 30 times more. So what happened? Whatever iron is taken, all these iron is increasingly getting absorbed. So what is the problem of this increased iron absorption? Again, another reason for increased iron absorption is anemia since birth. So all these things, what happens? What is this increased iron absorption? All this excess iron will be depositing in the iron storage organs. What are the iron storage organs? It is the liver, heart, and the skeletal muscle, leading on to secondary hemochromatosis. Again, reduced hemoglobin. So what will happen? Extramedullary hematopoiesis. So what are the extramedullary hematopoietic organs? That is the liver and the spleen. So the patient will have hepatosplenomegaly. So the reason for splenomegaly is one is extramedullary hematopoiesis, and extravascular hemolysis. Similarly, the reason for hepatomegaly will be one is extramedullary hematopoiesis, other is iron overload. Okay. And finally, what happened? Because of anemia since birth, the child will be dependent on multiple blood transfusions. So again, what is the hazard of multiple blood transfusions? Again, iron overload leading on to secondary hemochromatosis. What is the other problem with multiple blood transfusion? It is a transfusion transmitted infections. Okay, so this is in nutshell on the pathogenesis and the related clinical features in the form of a concept map. Here, I would like to emphasize something here. This one. This is something very new here. Erythroferron and hepcidin. Okay. So this is something, a new hormone which is being explained here. So what is this erythroferron? So erythroferron is basically a hormone which is produced from the bone marrow erythroid precursors. So what they say is this erythroferron inhibits hepcidin. So you're all aware that hepcidin basically regulates the iron absorption in the GIT. Okay. So whenever the iron storage is very high in the liver, hepcidin will go and say to the intestine that iron store, we are already full. So let me not absorb more iron. It will be like a toll plaza. It won't allow extra iron to enter from the intestine into the liver. So that is the role of hepcidin. So what happens? This erythroferron, which is produced by the erythroid precursors in the bone marrow. So this is going to inhibit hepcidin. So when hepcidin is not there, what will happen? All the iron in the intestine uncontrollably will enter into the liver. So this again will exaggerate this secondary hemochromatosis. So this is something which is new in the latest edition of Robbins. Probably you can refer a potential source of MCQ. So erythroferron, which is basically a hormone which is produced by the erythroid precursors of the bone marrow, which will inhibit hepcidin. So remember that. So this is the peripheral blood picture. So let's see the findings. As you can see, the arrowhead points to target cells, which are insoluble alpha chains. And these are the microcytic hypochromic RBCs. So anisocytosis, as you are aware, it is a variation in the size of the RBCs, anisocytosis. Poikilocytosis is a variation in the shape, as you can see in this picture. Microcytes, all the RBCs will have microcytosis. Hypochromic, yes, the color is low. And as you have already discussed, we have target cells. Basophilic stippling, important feature in thalassemia, and there are other causes of basophilic stippling, which I'll show you in the next slide. And reticulocyte count, as I said, it won't be correlating. Okay, so this is a peripheral blood picture. So coming to the basophilic stippling, as you can see here, this is the appearance of a basophilic stippling, like the blue dot-like things. So what is this basophilic stippling? They are the fragments of ribosomal RNA. And there are many other causes of basophilic stippling, which goes with the mnemonic of this. So what is this B? B is beta thalassemia. A is ACD. So what is ACD? It is anemia of chronic disease. And what is this S? Sideroblastic anemia is where iron absorption is not effective. What is this O? Other dyserythropoietic anemias. And what is this P? It is PB, that is lead poisoning. Okay. So these are the reasons for basophilic stippling, which goes with the mnemonic like this. Okay. So what are basophilic stippling? They are fragments of ribosomal RNA. And as you can see this picture, so this is a crooked or hair on end appearance, which is a classic picture in beta thalassemia major. So what is the treatment of beta thalassemia? It is hematopoietic stem cell transplantation. How do we prevent it? We have to do prenatal diagnosis through molecular techniques. So let's see a little bit on the diagnosis. So before that, let me tell you how the normal electroporosis looks. See, always remember, we'll make the hemoglobin run from here. So as it runs from here, from this negative terminal to the positive terminal, it leaves impression. So in the normal adult, it will be only hemoglobin A. So this thick band will be there in a normal adult. And as you can see here, there is a thin band here, very slight hemoglobin A2 will be there. So this is normal. Whereas in a newborn, some amount of fetal hemoglobin will also be there. So when you do a hemoglobin electroporosis in a newborn, you have fetal as well as hemoglobin A. Okay. Sickle cell disease will have a specific pattern. So remember this first, actually, again, whenever you're given to interpret hemoglobin electroporosis, remember this A2SFE. So this is the order. So from the origin, the first band will belong to A2, second is S, third is F, last is A. So A2SFA. So as you can see here, this is F and A, so it is newborn. So here A2 is not there, whereas S is there, so it is sickle cell disease. So this picture, you have S as well as normal. So it is a trait, a carrier. Similarly, hemoglobin SC, remember A2 is not only for A2, most commonly it is A2, but also for CEO, which are rare forms of hemoglobin. So when there is a band here, as well as in sickle, it is SC disease. Okay, so this is a control. So this is how you have to interpret a hemoglobin electroporosis. Remember this, the first band at the origin would be A2SFA. So this is basically a screening test for thalassemia, which is done in a resource poor testing. So this is actually a single test tube. Okay, so this is, they call this naked eye single osmotic fragility test. Okay, so this is the test, and what you see here, what we do basically is at 0.36% of saline will be used. Equal amount of saline and the patient's blood will be put into the test tube, and you rest it. What happens if there is complete hemolysis within 5 minutes? It is negative. So there is no hemolysis because these thalassemia RBCs will be resistant to hemolysis. So if the sample remains turbid, it means it is positive. So it is half turbid and half clear, it is suspicious. If it is complete hemolysis happens, it is negative. So how do we interpret this? As you can see here, these are the lines. So this is a paper at the back, and these are the lines. As you can see here in negative, you are able to see these lines. So when you are able to see these lines, it means hemolysis is completed. So this is negative. Whereas here, you are able to hardly see some lines. You can see, sometimes you cannot see. So this is suspicious. Whereas in a positive sample, see, you are unable to read the lines at the back. So that is positive. So this is basically a screening test done in a resource poor setting, but these days we don't use because we straight away send the patient for hemoglobin electroporosis, which is the confirmatory. So as I already said, A2, if at all any band here, it is S, then F, A. Okay, so here what happens? This is how, this is a percentage. In the first slide we saw, this is a hemoglobin A, some amount of F and A2 should be there. Beta thalassemia major, what happens? Fetal hemoglobin will be predominant and some amount of A2. Adult hemoglobin, that is alpha to beta 2, is almost very, very less. That is beta thalassemia major. In a trait, yeah, some amount of C, as you can see this picture in normal, it is till here. Whereas in trait, only some amount will be there. So that is the trait. Okay. So this is another electrophoresis picture where you can see hemoglobin A, that is the adult hemoglobin. Yes, so much is there. In addition, some amount of fetal hemoglobin is there and some amount of hemoglobin A2 is also there. So this is a classic case of beta thalassemia trait. So these people, they have a very high risk of misdiagnosing them as iron deficiency anemia. For these people, genetic counseling is mandatory. So coming to the next one, alpha thalassemia. As we have already discussed, alpha thalassemia is coded by identical pair of genes on chromosome 16. So there will be 4. Hydrops fetalis, where all the 4 alpha chains are absent, alpha genes are absent, it is hydrops fetalis. So these children will not survive, fetal death will be there, and the hydrops fetalis. So hydrops, it means massive fetal edema will be there. The entire baby will look like anasarca and fetal death will be there. Transfusion dependent, very unlikely for them to survive. Then if there is only one alpha chain, it is called hemoglobin H disease. So this is a severe thalassemia or transfusion dependent thalassemia. Then there are 2 alpha and 2 are missing. So that is asymptomatic with microcytic hypochromic red cells. So they are non-transfusion dependent. Silent carrier is 3 alpha chains are present, only 1 is absent. So they'll have the normal RBC morphology. See, sometimes you would wonder because in beta thalassemia, though it is encoded in a single focus on chromosome 11, even see, you can see that 2 alpha chains are not there. Still, the patient is only asymptomatic. Okay, why so? We'll see. So, as I said, see, hemolysis and ineffective erythropoiesis is less severe in alpha thalassemia. Why? Because the excess is getting deposited. See, we saw in the previous that the main problem in beta thalassemia is the excess alpha chain is getting accumulated, isn't it? Causing RBC membrane damage, leading on to ineffective erythropoiesis and apoptosis. What happens is this alpha polymers are there in alpha thalassemia, isn't it? So alpha thalassemias are more insoluble and cause more RBC damage. Whereas these things, the gamma 4 or beta 4 tetramers, so they are to certain extent soluble. So the symptoms and hemolysis will be less severe in alpha thalassemia compared to beta thalassemia. So the 4 gamma chains joining together, it is called Bhaarath's hemoglobin, that is gamma 4. If all the beta 4 chains join together, you call that as hemoglobin H disease. Okay. So to conclude, for thalassemia, it is genetic counseling is needed because early diagnosis or good treatment in case of thalassemia will not play any role. What we need to do is eliminate the disease. So the key home message in thalassemia is genetic counseling. And these days we have a lot of choices like amniotic fluid sampling or chorionic villus biopsies. And in that also we can do hemoglobin electrophoresis and we can find out. So the best strategy would be to eliminate the disease. And in North India, thalassemia is very, very, very predominant. So it is really very, very important that we need to screen the antenatal mothers for thalassemia and give them counseling. Thank you.
Thank you so much, ma'am.
Any queries, you can text me. I'm happy to reply.
Thank you so much. That was very good lecture, ma'am. And and I would like to add a note that every May 8th, we'll be having our World Thalassemia Day. Just a note on the history of World Thalassemia Day was the person who found the Panos Angelos, and his son died because of thalassemia. So to commemorate this day, he created Thalassemia International Federation, and through which he tried to break many myths regarding the thalassemia and make world a better place. Thank you so much, ma'am.
Yeah, one more to be added actually. I mean, Government of India has acknowledged people with hemophilia and thalassemia. And in all the central government institutions, there is a specific quota available for thalassemic and hemophiliac individuals in India. And all the drugs for treatment of thalassemia, for all the, I mean, there is no treatment, of course, whereas for managing all the complications, it is all free for all the Thalassemia Society people and Hemophiliac Society people. So that was a good initiative from the Government of India. And for the last, I think, 2 years back, the entire Qutub Minar was painted red on this day to create an awareness on thalassemia and hemophiliacs.
Okay. Thank you.